we are coming for the last lectures for the Professor Jorge Sinclair. He is a professor of internal medicine and critical care medicine, University of Panama in Panama. And he is going to talk about malaria and yellow fever since Jorge's till today. Professor Jorge, he is a director and founder of the ICU in the Pacifica Salud John Hopkins Hospital. And at the same time, he is the founder of the first program of the critical care medicine in Panama and Central America. And maybe the talk about malaria and yellow fever is a little bit strange now, but still endemic. And actually, I saw the report from the World Health Organization in November 2020. Still, many countries have malaria and yellow fever, especially in Africa. I don't know what exactly is the situation in Panama, but Professor Jorge may explain for us. And some person may ask, what is Corgas mean? He is William Corgas, and I think also Professor Jorge will explain for us. Okay, welcome, Dr. Corgas.
Good afternoon and good night for Egypt. It's a really honor for me to be in this meeting today with you. It's an honor for me and for all America because we want to congratulate all of you because your heart and your commitment to the education, and not only in Egypt, in your countries and in your continents. So in America, we are so fanatic of your lectures, and we are so proud to be here today, enjoying and sharing with distinguished professors from different universities around the world. You maybe say, why we are talking today about Williams Gorgas, and the malaria and yellow fever, when we are talking about the anesthesia and intensive care unit. Of course, I have 40 years working hard in the area of critical care medicine. But today, I asked Professor Sad if he was agree with me in order to talk something a little bit different, just with the same kind, with the crisis and the background we have in America and around the world in the case of the coronavirus. Of course, yellow fever and malaria is not a coronavirus, but these are diseases, both are diseases that we knew and we learned since when Fernand Lesseps come to America, and he tried to build the Canal of Panama.
Prof,
and this time, the Dr. Gorgas at that time really was so impressed why Fernand Lesseps was collapsed the Canal of Panama when he was successfully in the build of the Canal of Suez, one of the marvelous around the world. I have the pleasure to meet the Canal of Suez in 2 times when I visited Egypt many years ago. But in order to this, we have made, I believe, a few review and a small summary about what's going on, what's happening today about the tropical disease, including yellow fever and including dengue. In a geocentric surveillance network report, a fever returned travelers from different destinations spread across 6 continents. That means that during the period of 1997 to 2006, the febrile illness was reported in 28% of travelers achieved complaints. The most common cause of fever were systemic illness, what we see or what we understand like systemic illness. We can see in these pictures that the top 10 of the illness in returned travelers around the world, we have systemic illness that include malaria, malaria due to falciparum, Plasmodium falciparum, malaria due to the Plasmodium vivax, and malaria due to the other species of diseases, and mosquitoes. But what happened with dengue? What happened with salmonella and Turks, cerebral stiffy operative infections, and rickettsia? Acute diarrhea, respiratory illness, and genital diseases like IVU, and the gastrointestinal illness that is very common in Mexico when you visit a country like Mexico. The top 10 of these diseases means and included the period incubation diseases less than 7 days and more than among in the 7 and 21 days and more than 21 days. The common disease that we knew and we know about the other malaria, the traveler's diarrhea, dengue, enteric fever, respiratory tract infections, and others like rickettsia, leptospirosis, meningitis, yellow fever. Like you see, many of the diseases that attack of the human being with the parasites, mosquitoes, and tropical infectious waves that put the patient in the ICU and can attend to the life of the human being. Between 7 and 21 days, the more common are malaria and enteric fever, and others, rickettsiosis, hepatitis, leptospirosis, HIV, Q fever, etc., etc. And more than 21 days, malaria again and enteric fever again. That means that the malaria and dengue and the mosquitoes travelers patients that had been attacked means that there can be present between the first date, less than 7 days, and the more than 21 days. That this means that we have a very tough problem in the tropical countries like Panama, Central America, Caribbean, and other countries that we have mosquitoes around the world. A case presentation. We have now a case presentation. It's a patient, a male of 32 years old, with clinic presentation with fever for 7 days, icteries, jaundice for 3 days, confusions, and 1 day for 1 day. At the clinical exam, we have a temperature with fever, high fever, pulmonary respiratory beats, beats, heartbeats more than 128, and respiratory frequency of 24 by minutes. The blood pressure, can you see and can you appreciate it? Is a patient that is lowering his blood pressure, his systolic and diastolic pressure, icteric, confused, disorientated, hepatomegaly, many clinics, signs and symptoms that today we can translate like a Q SOFA score that we read every day in our ICU, like Apache 2 and a Q SOFA when we want to schedule our patient. That patient, we have an acute undifferentiated febrile illness less than 14 days, and undifferentiated initial symptoms and things no contribute to know what is going on with the patient. The fever with an oral temperature was very, very high. What could be the differential diagnosis with this clinic presentation that I show you? We can think in a malaria with Plasmodium falciparum. We can think in a scrub typhus. We can think in a leptospirosis, or we can think in dengue fever. I would like to know what you think about it in the audience about what is the answer to these 4 questions. If somebody are interesting or is interesting to respond, is fine. But what happened with this presentation is very similar. We can be confused with this presentation. And the answer is malaria. Malaria is a disease that is still is burning and producing many problems around the world. And that's it. That's transmitted by the mosquito anopheles, and another kind of mosquito around our countries in Central America, Caribbean, and other countries of the world. What are the facts about that? An estimated 260 million clinical cases and more than 500,000 deaths due to the malaria were reported in 2010, mostly in children aged less than 5 years old, living in sub-Saharan Africa, and there, here, we are not estimating the people that are dying in America too. It is estimated that approximately half of the world's population in 100 countries live in areas where malaria is still transmitted. And you can see and you can appreciate in red all the countries, including the United States, the south of the United States, Central America, and the south of Mexico, and part of the South America, and all Africa, including some area of Egypt and Cairo, aboarding the Suez Canal, including India and including Australia in some place. That means that those diseases, malaria and yellow fever, are diseases that we still cannot be controlled around the world, and we have to know why it happened that and what happened with Dr. Gorgas in Panama when he came to Panama, and he could do it, and he could treat it and control, when now around the world we cannot do it. Yellow fever, malaria, and the build of the Panama Canal, in a historic perspective, we can see that Dr. Gorgas was the more important guy when he analyzed the why Professor Ferdinand Lesseps couldn't failure in the build of the Panama Canal when he came to America. He was very successful in Europe. He was very successful in the Middle West, but he collapsed in Panama in the campaign Universal Canal Interoceanic in 1882. Well, we can see original pictures, photos were 1882 in the hospital, the El Hospital du Notre Dame, and where we can see the first areas where Dr. Gorgas and the Ferdinand Lesseps, when he gave to Dr. Gorgas the project, we have a hospital, a small hospital where the patient was recruited to be treated against the malaria. In this graphic, we can appreciate some in blue and in red 2 points very important. In blue, we can appreciate the percent of mortality rate, total mortality rate during the period of the French with Dr. Ferdinand Lesseps, and during the mortality when Dr. Gorgas arrived to Panama in 1919. We have the cases, the number of cases, and we have in red the number of mortality cases. That means during the French period and the French Canal bankruptcy in 1888, the percent of cases and the percent of mortality was really, really high and very tough to the project of of Dr. Ferdinand Lesseps. What's going on? What happened? The workforce came to Panama, and then in the years of 1904, after the independence of Panama from Colombia, Dr. Gorgas arrived to Panama with a very potentially and successful team of scientific from the United States that decide to fight against the mosquito before build the Canal of Panama. And we can see after 1904 how the number of cases and the mortality from mosquito fall down significantly. And we see when the Canal of Panama in 1940 opened the doors to the world with the sheep and corn, no mortality we had in these periods because Dr. Gorgas fight it again first with the mosquito and then built the Canal of Panama. In 1928, Dr. Gorgas and Panamanian government built the first institute of tropical disease in America, the Gorgas Institute, that today we have a very, very great successful campaign against the coronavirus. And we can reduce and typify all the kind of the variabilities of the coronavirus that we have seen in our country and Latin America. Well, this paper was original paper signed by Dr. Carlos Juan Finlay, that was who discovered that mosquito produce the dengue disease, yellow fever, and malaria in Cuba in the year of 1881. The Aedes aegypti produced the yellow fever, and in that moment, in before the beginning of the build of the Canal of Panama, the government of Panama and the United States together created a commission with Walter Reed, James Carroll, Aristide Agarholm, and Jess Lazarus in order to fight against the mosquito before the build of the Canal of Panama. In this photo, we see a wonderful group of scientists: Dr. Gorgas, James Green, Lazarus, and Walter Reed, that they create the commission to fight against the mosquito. Dr. Gorgas, who were Dr. Gorgas? Dr. Gorgas, William Crawford Gorgas, was a man of 49 years old, gentle, white-haired, whose cheerful eyes and happy nature hid an admirable tenacity. He earned in that time $4,000 by year. The administrator of the Canal of Panama won $25,000 by year. That means that the doctors at the scientific always we are losing compared with the administrative. That means that today the politicians and the administrators still are winning more money than the scientific and the doctors that when we are who treat the patient. It's not fair for the science, or no? Okay, Dr. Gorgas was an admirable man. He created a pilot ICE where, together with Carlos Finlay, discovered the theory of the mosquito transmission in Cuba. Walter Reed demonstrated the intrinsic incubation period from 12 to 20 days. In Cuba, in 91, we knew about the effectiveness of the application of some tropical plants against the mosquito, and the elimination took about 8 months when they create this pilot ICE. In medical or military history, nothing compares to this war against the mosquito. That means that in this moment, in the first papers that create a good and a great moment in the history to fight against that. In Colon, the north of Panama, in June 1904, the Isthmus of Mosquito Paradise was created. That means that in that moment, we create a very tough group and team that means that we are fighting in the right way. The Isthmus of Panama was called Mosquito Paradise. You can imagine that. For very noon, and it was called to address yellow fever zones. Malaria greeted street, but yellow fever, that means in that time, synonymous of panic, death. Tenacity was the principal profile of Dr. Gorgas, and it's helped him to attack and to treat the mosquito in that moment. The Gorgas Hospital began with a small areas where they call, of course, they call a little bit ICU areas, isolate areas, in order to avoid the contact of the patients with another ones. The malaria continued to be the more highest and dangerous disease in those times. Okay, what about the malaria? The pathophysiology of the malaria can include the mechanical microcirculatory obstruction, causing the situate adherence to the vascular endothelium of parasitized red blood cells, sequestration and obstruction of small vessels. The second one is an intravascular hemolysis. This one is a very interesting graphic when you can see the mosquito beating the skin of the patient and introducing, well, the sporozoitos, hypnosotoisos, and then have a transformation well, the hepatocytes from the liver suffers acquisitions and breakdown inside with ruptures and dissemination of them into the blood schizophrene and then transmitting around the blood and the circulation. The clinical features more important to the diagnosis, it was the fever. And you can see here how the fever fall down after the anti-malarial treatment, significantly, and meaning that the treatment was effective. The severe malaria can can be appreciated like cerebral malaria, unresponsible coma, not attributed to any other cause in patients with falciparum malaria. Severe pneumocytic anemia, less than 5 grams by deciliter, hypoglycemia, metabolic acidosis, acute renal failure, ARDS, shock, disseminated intravascular coagulation, hemoglobinuria, and hyperparasitemia more than 5%. That means that the parasitological diagnosis can be easily done by microscopic and by rapid diagnostic tests like um, we call antigen detection and Buffy quantified blood, uh, quantified buffer code in blood. Why the diagnosis of microscope is very important? Because in some poor countries, maybe we don't have the high technology to make the diagnosis. The microscopic diagnosis have a low cost, high sensitive and specific diagnosis. You can make the species identification and the quantification of the same one. The quantitative buffer code test have a staining of the centrifugated compressed red cells layer with acridine orange and examination under ultraviolet light forms. Comparison with peripheral smear is faster, more sensitive, species identification possible, specialized equipment, and consumables expensive. It's more expensive. Rapid tests can include immunochromatographic tests and the capture of the parasite antigens from the peripheral bloods using either monoclonal or polyclonal antibodies, histidine-rich protein 2, and pan-malaria and parasite-specific LSD. Well, in 2012, the World Health Organization decided and sustained that the universal access to malaria and diagnosis testing it was necessary, and they created the operational manual in 2011. They created the guidelines for the treatment of the malaria and secondary stage of the 2010s, and this disease surveillance for malaria control and disease surveillance for malaria elimination in 2012. The guidelines for the treatment of malaria focus in two sensitive points: the sensitive regions and the resistant regions. We can see to the all plasmodiums, so Vivax or Plasmodium val or Plasmodium falciparum, anyone, they have two more important treatments: the chloroquine phosphato with or hydroxychloroquine 2 plus primaquine phosphato for area with sensitive region. And to the resistant region, they added lumefantrine with atuvoquine proguanil plus quinine plus doxycycline, that is a kind of penicillin, and tetracycline or clindamycin or mefloquine, specific to the resistant region. And those we can see that they can focus in two sensitive areas, sensitive and resistance, with with almost the same protocol. In the intensive care management of the severe malaria, we can have to medication with diazepams, parallel for the convulsions crisis. Of course, you can use another anticonvulsive drugs, Keppra, acid valproic acid, etc., etc. The management of fluid balance is very important to optimize the delivery of the oxygen and to reduce the metabolic acidosis metabolic. Prompt patient treatment and angle of 45 centimeters, intubations, and the management of diuretics to pulmonary edema can be used. Careful monitoring and correction of the hypoglycemia, continual electroencephalogram, patient with convulsions and seizures, The blood spectrum antibiotics to management of the shock and secondary bacterial infections in the ICU, including gram-negative, including another ones, kind of the disease. Exchange transfusion is needed to be considered if the parasite density is more than 10% of there is spontaneous bleeding. And maybe we have to change the blood and use including main measures of platelet in order to have and to take a infusion of platelet, fresh platelet. Well, just to finish, we have to mention again what was the Gorgas strategy versus the current strategy to treat the tropical disease, including malaria, yellow fever, and all of these diseases that are included in our question. Well, sorry. Okay. Gorgas, Dr. Gorgas, in that time was inspired in the bridge together with discipline, military structures, strict supervision that compound a team that fight against the mosquito. That means that Dr. Gorgas was very, let me see, okay, interested in the elimination of the source at the breeding sites using the nets mosquito in the windows, isolated of caves in quarantine contacts, water barrel covers, drains, landfills, sewers, spray sulfur, and oil. The oil was on the more easy and cheaper way to treat and to fight against the mosquitoes. Fines to refractors refunded if deficiencies corrected. Was very important to Dr. Gorgas, the personal and the group education. One inspector in that time, attended 1,000 inhabitants, and the investment for this inspector was $10 for inspector. Today, we have no motivated brigade for contrition. We have a lot of bureaucratic structures, occasional supervisions. We don't have elimination of breeding sites. The waters, barrels, nor covers. The negotiation intra per homes are very insufficient. Fines to retracted without enforcement power are deficits. The personal education is deficient. And one inspector is dedicated for 10,000 inhabitants for area. The investment compared with Dr. Gorgas in that time was $10, now is $1 for habitats. That means that we are lost in many countries. The sensitive and the profile and the essay that Dr. Gorgas had in the 19th century. That means that maybe we have to see how Dr. McCulloch in 1977 took this photo, talking about the point at maybe we have to return to the protocols Dr. Gorgas had in that time. With this, I want to finish my lectures. I want to thanks for your patience. I spent more time maybe. I so proud and so glad to share with you. And I are the hope to wait for all of you to visit Panama in the future, my country, where we send to you our warmest and very warmest regards. Thank you very much.
Thank you very much, Dr. Jorge, for these interested lectures. Actually, I didn't read about malaria since long time, and I have to read some report from the WHO before your lecture. Now we have some few questions. And first questions from Dr. Ahmed. What is the management plan to eliminate malaria from the world? What is the general plan for that?
Sorry, repeat me the question because I hear a little bit slow. What is that? Let me see.
Yeah.
What is the management and plans to eliminate malaria from the world? Yes. Well, this question is very interesting because for this reason, I'm talking about that maybe we need to talk to retake the same protocols that the global guys have in the 19th century. That means that the problems is not a scientific problems. The problem is a problem of education. The problem is a problem of the to avoid the bureaucratic system that our country has with our peoples and with health care systems. We need to take and return to retake again the public health system and support the public health protocols in order to avoid the brain infection of the mosquito around our lakes, our countries, our streets. I have many photos. I have more than 1,000 photos. How the streets, the avenues was clean in 19th century compared with today around the world in our countries. That means that more that to treat the patient with hydroxychloroquine, we have to make and retake the protocols in order to avoid the disseminations of the mosquito.
Okay, yeah. Actually, I think still we have a lot, especially in Africa, to control this chronic problem. Now, if you have another questions about the incidence of malaria infection with blood transfusion.
Yes, it's very interesting question. Very interesting question because here in Panama, we have the Gorgas Institute. And the genetic manipulation we are doing right now is avoiding that the female mosquito is pregnant, okay? And then we left that some mosquitoes can go ahead around the cities, but avoiding that the female mosquito can be pregnant. And in that way, genetically, we can change the reproduction of the mosquitoes and avoid that the little eggs can be disseminated in the city or in the country. It's one of the way that we are trying to we are doing here in Panama and in Brazil too. Brazil is the more important country that has this protocol in order to avoid the dissemination of the female with the eggs, mosquitoes.
Yeah, we have more questions about the genetically modified mosquitoes. Is it possible to be some way to control the malaria? Genetically modified mosquito.
Genetically, why? What?
You can see the questions in the question box. genetically modified mosquito, can it have some effect on the related?
Well, like I said before, when we fight genetically with the mosquito, we avoid the reproduction of new mosquitoes. And we avoid the reproduction of female mosquitoes that had the potentially force to produce more and more mosquitoes. We are now eliminating the transmission to the female in order to avoid more mosquitoes. It's the protocol that Brazil and Gorgas Institute. Of course, we are trying to retake all the protocols against the public health systems. It's necessary. We need to follow against the mosquito in all the areas, and the government have to be, not my government, all the government have to be very serious in the topic of treat the mosquitoes, dengue, chikungunya, or all of this kind of tropical disease.
Yeah, just my questions from myself. Your choice for this topic, malaria and yellow fever. Are you facing this problem too much in Panama? What is the current situation in Panama regarding the malaria and the yellow fever?
The blood transfusion question. No, the blood transfusion question is just only to patients when they are suffering from intravascular coagulation and intravascular coagulation in the ICU, and patient with less of 3 grams of hemoglobin. That's all. We never transfusion when you have 7 grams, over 7 grams. Never, because you can produce many problems with the lung, many et cetera. We try to avoid the transfusion. Something very interesting, the people in America and the people in Africa that suffer from some disease of hemoglobinopathy, they know suffering from a yellow fever and don't suffer from malaria. It's very interesting point.
All right. Thank you so much, Professor George or Corge, as I told me. And hopefully we can see you in other meeting talking about the critical care topics.
I promise to you to the next time we have a very tough conference about the ICU critical care medicine. But I think all of you are very smart, and all of you are very so distinguished professor, and you are, I learned with you, and I decided that this topic maybe could be interesting for you. I'm so glad to be here today, and I hope to see you soon. And be careful with the coronavirus. We are making in Panama, making studios, and making researchers with the Gorgas Institute to treat the coronavirus. In Panama, we have a very good standard of vaccination in the population. And the next time, maybe we can touch something about that.
You may arrange your Saad. Your time, Saad, now to talk.